Um, my name is Rick Schepler, and I am the director of the Center for Innovative Practices at Case Western Reserve University. Joining me today is Michael Fox, also with the Center for Innovative Practices, and he's our lead on co-occurring disorders for youth. And this is part of our regular learning community that we do on co-occurring disorders, substance abuse, and mental illness for kids. And today we're going to focus on the impact of COVID on the work that we do. We welcome your questions in the chat box. Mike, I will let you monitor those. I want to make sure you have something to do while I'm talking the whole afternoon and you're sitting there just watching.
That is my plan.
All right. So without further ado, some reminder stuff about how to get more information on our learning community at Ideas at the Institute. And more information. Okay, I'm going to start talking about COVID threats and risks to our population that we serve. There's some very specific, unique things that affects our population. Number one, because kids who are using substances often are either vaping cannabis or they're vaping cigarettes. They're more at risk because of decreased lung capacity. This is more true of adults being homeless, but it could also be true of some of our older teens. A lot of the kids who are using traditionally have, received charges and they could be in lockup. And, each of these areas has increased risk for either getting COVID or the results of getting it might be worse. And then, again, with kids, this is rare, but if you have kids who are using opiates or methamphetamine, those two drugs in particular compromise respiratory and pulmonary health. So we want to, again, put these things on the table just for you to think about. These are increased risks for some of the kids that we are serving.
Hey, Rick, I want to interject, and not even specific to that, just as we were talking about the youth and the families that we serve, you and I we talk about these youth and these families all the time, but for people joining us, it is specific to youth with, the title is co-occurring disorders, but as Rick and I really define it, it's youth with multiply occurring needs. That is, there's multiple areas of need. If you have been with us in previous discussions, you've heard how we define youth with these multiple areas of need. But when you have something on the mental health side and something on the substance use side, and then very often with the kids that we're working with and the families we're working with, there is some level of complex trauma, developmental trauma, intergenerational trauma, things like that, that then lead into a lot of the other areas that, Rick, you just alluded to. It could be homelessness. It could be what we don't think of as necessarily direct drug and alcohol use, but vaping is definitely on the list, probably predictive of more dangers coming up than any other drug. Predictively, with opiates and methamphetamine on this, certainly you can't get much more dangerous than that. But so these are the youth and the families that we're going to be talking about today. So
thank you. I appreciate that. All right. So let's talk about some more impacts. And this is on availability and drug use. So what's also interesting, as I was researching the information for this, is that the illicit drug supply internationally has been disrupted. And this particularly affects methamphetamine, cocaine, and opiates. So what does that mean? Well, it means that a number of things. One is that potential surge in drug availability once COVID travel restrictions are eased, and that drug might have a higher purity. You might see persons trying to stockpile the drug of choice that they use. You might see a substitution of or other drugs that might be more dangerous. You could see withdrawal because they can't get access to the particular substance they were using. We're seeing more polydrug use of alcohol and marijuana because of this. And there's an increased likelihood of illegal activities to get drugs due to the increase in price and the economic downturn. So again, this is all new to me, and I thought it was really interesting information, and I wanted to share just because of the multiple different impacts. We're usually talking about different kinds of impacts, like, well, if I can't go out to the home to deliver the service, how do I deliver it? Well, that's certainly an impact. But some of these other impacts are ones that we don't necessarily notice. And I wanted to put them out there. And I'm going to stop a second. Mike, if you want to comment on any of these, please go ahead.
Thank you. You know what? When we're in front of a lot of other people, it's the only time that Rick, my boss, actually invites me to make comments. Usually it's the opposite.
That's correct.
With the decreased supply, that's definitely something that has been noted, not just in the United States, but as you mentioned, everywhere. One thing that doesn't necessarily match that, though, I don't know if any of you had time to note this with everything else that's going on, but the CDC and then noted by AMA here recently, there has been a suspected uptick, and it's hard to track right now because everything is so COVID focused. It seems like there has been an uptick in overdose, both in non-lethal situations and in lethal situations with opioids again, after it had leveled off for a little bit. But now in the midst of the pandemic, it seems like it is increasing, and there is an increasing connection to fentanyl and the fentanyl analogs. So drugs are less available, but as Rick mentioned with substitution, I think a lot of drugs, it's not necessarily that somebody's looking directly for fentanyl. Maybe they're looking for cocaine, and cocaine has been adjuncted to, that's not a phrase, but it has been added to because the availability has decreased and the fentanyl is easier to get, and so people are overdosing, not necessarily even trying to be overdosing on opioids. That doesn't necessarily directly impact the youth that we're talking about, because the youth that we're talking about have shown a sustained tendency to purposely stay away from opioids, but it definitely impacts their families, their caregivers, and the communities around them. And so this has a lasting and major impact. So there's me 2 cents.
Great, thank you. So while heroin might be harder to get, fentanyl might be easier to get. It just really depends on what the availability is and what has to cross borders and those kinds of things. All right, so impact on COD treatment. So it impacts the way we do our work. Most of us are doing telehealth now. I wanted to break it up into 4 areas: engagement, assessment, treatment, and transition. Obviously, engagement is more difficult to do over a telehealth modality. Your assessment, you have to address and assess different areas. In terms of treatment, you have to have an increased trauma perspective, and I'm going to get into that here in a minute. And we need to talk about transition and timeframes for the episode of care, because that might change given we're using this telehealth modality. And it seems like the episodes are like stretching out a little bit, right? We can't get everything done in the usual time frame. It's harder to do referrals and transitions to other new providers. So we are tending to, stay on with the families we're currently working with. All right, so I'll go into each of these a little in more detail. So engagement. Youth who are involved in juvenile justice may believe that they are less likely to receive a probation violation for non-participation in some sort of mandated therapy. We've seen a lot less activity from the courts, at least locally, and it's mostly because of, they can't get out and to see the kids in the same way that they used to. So kids are also seeing this and they're thinking, well, I'm not going to get in trouble now. I'm going to go do what I need to do. And I don't have to do that therapy thing. Or I can blow that off. So engagement around therapy when it's mandated, usually we had the court back up on that, and it's just less impactful now. One way you can join, and particularly with the family itself, is to utilize the shared experience of COVID that we're all having to join with the youth and families. None of us have been in this situation before. It's new ground for all of us. How's your family doing? Oh, that's interesting. We hadn't experienced that yet. And you could have a dialogue about that. It's a good way to engage. And then really importantly, it's important for families to feel connected, stay connected. And so our job also is not only to engage, but also to help them feel connected with the outside world. Anything on this, Mike, that you wanted to?
Observationally, and really I'm interested in comments from those of you participating along here. We have the opportunity where we work with a lot of teams, and most of our teams right now are around the state of Ohio. So there's, it's kind of an encapsulated view, and I'm curious how other places are doing it in terms of the youth on probation, because that is, traditionally where we have gotten a lot of identification, and then, if not referrals, at least collaboration on the treatment side with juvenile justice and probation. In all of our communities that I work with, juvenile probation is really just now starting to come back online, and even then it's in a pretty limited fashion. And like Rick was describing, youth and families, it seems that the ones that were more deeply involved, in the juvenile justice system, they had the same level of disconnect from probation because they couldn't go out and see their youth and check in with their families, and it's easy to sidestep phone calls, and they really did drop out of contact quite a bit. And I'm wondering if any of you have some strategies that work with that, or if any of you have noticed some of that same impact and influence. So.
And you can put that in the chat
Yes.
as we go. But that's certainly one of the areas of impact that we're seeing. When you do your assessment and you're looking for impact on youth, I would advise us to look at COVID's impact on different developmental stages. For example, normal teenage activity. So if our kids, because they're still developing, they're more likely to be more impulsive, risk takers. But that now has bigger ramifications. So if they're risk taking by going out and being with other drug using peers or something like that, whenever you're around other people, and if you're not following guidelines, you're putting yourself at risk. So this gives impulsivity and risk taking a whole new dynamic in terms of our kids. And as Mike was saying, anecdotally, we're seeing our kids just, leave and go, And the parents might even say, "Oh, I'm getting a break." But there's a ramification around COVID for this. You also need to assess for experienced grief and loss. Adolescents might have experienced, a COVID death. More likely, they might have missed, one of those critical milestones in their life, like, senior prom, graduation. Sports has been totally shut down. What if it was sports that was keeping our kid from using? Or during the season they didn't use, So you have to think about all of these things in terms of adolescent development and what they're missing. And I think COVID, especially for youth and teenagers, has really more adversely affected their development than any other age group. And then I'm also going to be assessing for increased isolation, anxiety, fear, depression. So for our kids that have internalizing disorders, you certainly want to check in on these variables as well.
Yep. Okay. Yeah, there's a couple of different directions to think about, and you really identified it with. For those with internalizing disorders, this can be disruptive in horrible coming back kind of ways. And then for a lot of the youth that we work with, there's a lot of externalizing, things going on. And I think the developmental perspective is really the most important centering piece to keep in mind when trying to contact with and individualize and match treatment for youth who are referred into our programs. Being very mindful of what their developmental tasks are, which are to increase their sociability, increase their independence. Part of that is done through an increased willingness to take risks, and all of that matches then with the impact from the pandemic. So it's woven together in ways that we can't separate. We can't just talk about a kid's experience of depression or a kid's increased marijuana use without also considering these other factors.
So it calls into question, then what do we do about it, right?
Right.
So then how do we consult and coach, caretakers and parents around, are there safer ways for their children to get out? Are there safer ways for them to be, settings, right, for them to be in? What protocols, are they getting coached on? And, it's about supervision and monitoring, especially with the kids who have externalizing disorders. Okay. So let's talk about the impact on families for a second. So the COVID impact on families is multiple. Number one, pretty much down the line, there's a financial strain on families. There's job losses. There are decreased days at work. Or there's a risk of a job loss, which is always stressing to a family. This is a new budget cycle for many of us on the phone. And I'm wondering if many of you are also experiencing that kind of anxiety around, will they cut our funding this year? Will they decrease our funding? What's going to happen? There's an intensification of family dynamics. So it really could increase emotional and relational reactivity. We're having to stay in small spaces together with the same people for long periods of time. I'm sure each of you have your own story. And, there's been an uptick in family violence, domestic violence, so family safety becomes an issue, so you want to assess for that. New roles. Well, for those of you who have school-age kids, you know this one. It's about parents as teachers and having multiple roles as a parent now and trying to do everything, including get your job done, get your 40 hours in, make sure that you've done all the, help your child through all their assignments. And good luck then, because you still got to go get groceries and everything else you normally do, right? So everything's more stressful. There's more things going on, multiple roles. And we're all trying to find hope in this. And, as you know, right now, there was this small window in early June, and all of a sudden now we're back into the highest peaks we've seen nationally. So it's kind of, this cycling. And so this really is truly a marathon, not a sprint. How do we deal with that? And how does that impact families? I was just having a conversation the other day, and, the conversation came up, wait till the new school year. And I said, what do you mean? They said, well, if this thing doesn't go away, that means parents are still going to be teachers in the fall. And so we need to be ready for what that means and how we help families. You need to take a look at caretaker anxiety and depression. So it's not only how does the kid handle this, how do the caretakers handle this? And then how does that impact the child? Assess for compounding impacts of COVID on families of poverty. So, increased social isolation, increased poverty, lack of technology is a big one. So in our attempt to help all families need to have technology now. And not all of our families have the kind of technology that is needed to receive that help. Health inequities in particular is quite evident in COVID. So I just want to pay attention to families of poverty as well. I think we need to assess that and what additional things they might be experiencing with the COVID crisis. And just in general, assess how health issues impact family functioning. So if one person gets hospitalized or COVID enters the family, how does that family deal with that? Or if an extended family member, like a grandparent, gets sick and the family can't go visit, how does that impact family functioning? So each of these areas I would be taking a look at as I work with families during the crisis.
Yeah, it really increases the importance of doing a fully integrated screening and assessment process when it comes to that, and emphasizes, as we've talked about, the importance of revisiting screening and then following up with assessment, even on active clients, not ones who are just coming to us for intake. But this is the perfect opportunity to really coach, in supervision and maybe even ourselves, in terms of it's important to continue screenings all the time. And for all of these different areas, for youth and families that we're working with that on an ongoing basis. This slide, Rick, just has so much good, pertinent information in it that, and hopefully if people have ideas on, hey, we found this that works, I'd really like to hear it. And I would like to point out that there is a chat box function that it seems many of you have not discovered yet. I know that we are hours, if not minutes, away from the start of a long weekend, and you're trying to wrap up email and things like that. But if you do have things to add to this, by all means, like the Samly. Boy, I am ready for the future.
You are ready, Mike. Yeah, you're ready.
But the family safety and the family violence, there have been articles in several papers spread across the country. I'm familiar with in Los Angeles and someplace in Illinois that I recently cited, where referrals to Child Protective Services, child welfare have just dropped off the board because all the mandated reporters now, are, if they're lucky, having video conferences, and that's at the very best. And so much of this now is hidden, and I think about how all of the points on this slide really relate to an accumulating ACEs score. I think that on the other side of this, ACEs might just include the pandemic as an automatic checkbox for so many of us. So that's
great point.
Yeah, that's it. And that's my sales pitch about the chat box again.
Okay. No, I love it. And I hadn't thought about the impact on child welfare or the welfare of children, and mandated reporters. But, again, these are things we need to stay on top of so that the more that we share with each other, we just learn from each other. I find this to be the perfect time to have learning communities, because learning communities are those things that, we get to share new information and, hey, it worked for you. Did this work for you? And the COVID crisis really lends itself to that. But yet, Mike's still no one in the chat box, so we're still looking forward to that.
And keep in mind that if you don't add in the chat box, then really you just get the perspective of Rick and me. And
that's a good one, but yeah. All right. So, I began thinking about COVID from an elevated suicide risk standpoint. And when you think about it, when you add the variables together, increased isolation, decreased access to important relationships, like supportive relationships, could be a family job loss, maybe financial debt, increased relational conflict, loss of connection and hope, a change in drug availability, increased depression and anxiety. Any one or all of these factors, when you combine them, could lead to an elevated suicide risk. So when Mike talked about this ongoing screening process, I think it's really important for the kids we serve, because this is a time of loss. This is a time of not having access to some of the same coping things, whether they were healthy or not, mechanisms that they were doing. Because of that, there could be increased isolation, increased depression, and what does that mean for this youth? So I just want to put that out there because I think, we need to be on top of that as well. And doing screening and assessment through telehealth is harder because you miss stuff. You're going to miss some nonverbals. You're going to miss getting the same amount of information you got before. So you need to stay on top of that.
There's always good stuff. There's always plenty to add to this, but I do want to point out that we've had a couple of additions to the chat box, and I want to thank Cynthia and Kristen. Cynthia notes that teen clients are definitely struggling to stay abstinent, and that increases really opportunities and even the onus on us to help parents, and especially foster parents, and that is such a true comment, to help make positive activities available to teenagers. And it is so tough to make positive activities for teenagers, that they're going to buy into. You can't do, paper bag puppets with teenagers. They're just not going to be impressed with those kinds of activities. So they do need to be realistic. And things that kids are going to buy into, and kids that are already, and Rick has talked about, I think, the grief and the loss in terms of the lost relationships, and then that really ties right back into the suicide risk.
So did you learn that utilizing paper puppets?
Paper puppets, that's right.
Yeah. Did you learn that wasn't effective with teenagers by trying to use it with your own teenager, or?
I did, yes, and he glued googly eyes on me, and it didn't work out. It turned out well.
It didn't work well. Okay, thank you. All right, so we're on to treatment adjustments, and thank you.
Rick, I want to add one more thing, from Kristen, who is a transitional coach with teens, which is it's an increasingly recognized, so useful thing to have available. So thank you, Kristen. Working with kids who have aged out of the foster system and seeing that elevated suicide risk just because of all of the things that you noted. And the important piece on the other side of that then is making those connections available and readily available. So thank you. Thank you, Kristen.
Yeah, and just kind of confirms what we were seeing in some of the journals and the the very real-time articles that we were reviewing. So increased drug use, increased, suicide risk, which means we have to stay on top of that.
Right.
Okay, so treatment adjustments. So, we're going to have to adjust expectations for what can be achieved. It might not be the same. It might be different in many different ways. We need to pay attention to the basic needs of the family. So not only from a treatment perspective, what are those other needs that the family might have that are getting in the way of them being successful as a family? I'd be staying on top of all the food banks, all the financial support stuff, and all the healthcare stuff that they might need. So you need to be a main resource to all the families that you're serving. And so part of our job collectively is staying on top of that in our local communities. You need to address any changes in the youth and the family support system or availability through, of their supports to resource and support building interventions. Again, we work with many families that may be resource poor, and COVID might have just made any one or two resources they had or supports more difficult to have access to. From a treatment standpoint, family therapy is just harder to do via telehealth. I challenge all of us to think about how many people can you squeeze into a screen at one time? And what kind of topics would you discuss? And, I struggled with this and I thought, I don't know that I would get all of that. I would get all that challenging. I would not get all, I wouldn't deal with hot topic issues because I'm not able to, I don't have as much control over the helping through telehealth as I would in person. So family therapy, I think in particular, is harder to do. Maybe you can probably do some dyadic work with two people talking. But that's also hard. Again, it's about how many people can you put in a screen. You miss a lot of the nonverbals. You miss when things start to escalate in a session.
Right.
So, it's just hard.
Yeah, it is. And following up on that and coming from the chat box, Cynthia notes that her families are using laptops and then passing it around, kind of a round robin family therapy. And those are families that have the resources to have a laptop, or maybe they're supplied, and so you don't even get the different boxes that you get to see. It's not the Brady Bunch. A lot of times it is you're passing the phone around if they have that level of availability. And as noted by Angie, some of the youth that she's working with, and I really like this note in the way you framed it, Angie, and that some of our youth and our families are so marginalized. That this assessment that you're talking about here, Rick, with paying attention to the basic needs, if our families are already struggling with the basic needs and are at the margins, so to speak, anyway, this just becomes so much more important. And how do we balance with? And I'll bet you a lot of you that are out there working in the field, if your agency or your company is saying that you've got to do telehealth, that you're just chomping at the bit, that you're really ready to go out there and risk your own health, in terms of being out there and being hands-on, because it's just some of our families are in such high level of need. So.
Mike, you really talked about it well on the last slide, which is, we need to utilize a trauma lens in how we do all of our treatment, because this is just inherently a traumatizing event. Which I will get into more in the next slide if I can ever move the slide.
And Mary Moore also notes, and Mary, I really hope that your middle name is Tyler. She notes that it can be impossible to recognize anxiety and so many other symptoms over the phone. Let alone if you're doing telehealth, video conferencing telehealth. But if it's reduced, especially to the telephone, that's an okay modality for maybe more cognitively based adult clients who are at a more active level of change with fewer of the complexities that we're talking about. But as the level of readiness decreases and the complexity increases, those things are so hard to assess over the telephone.
Yeah, absolutely. Yeah, that's a good one.
Now, her middle name is not Tyler, so, and I wasn't the first to notice that. So.
I'm quite sure of that, and she's probably tired of hearing it.
Probably.
By now. Okay. So, Bessel van der Kolk is, a well-known trauma author and trainer. And he put out a brief like a month or two ago that really summarized some framing that I thought was helpful to therapy. And one of our colleagues, Kim Meyer, read the article. And so we developed actually a set of like telehealth interventions based on this kind of a theoretical framing. So what he said was there's increased lack of predictability in people's lives, much more immobility, there's a loss of connection. These are all symptoms of trauma or pre-trauma, numbing out, spacing out. Just think about yourselves right now. Loss of sense of time and sequences. Today's Thursday, right? I think. So, I mean, loss of safety, loss of sense of purpose. So this is really kind of a numbing experience for all of us, but also our families. So what does that mean? What impact does that have?
Yeah, and so these are things that most of you probably already recognize working with youth and families with long histories of complex trauma, because that's descriptive of what the youth are already living with a lot anyway. And that loss of safety and that lack of sense of safety is so pervasive that it really is the deciding factor in all of these other things with some of the depersonalization and the reactivity. And so this is just emphasizing it. And if I'll bet you everybody on this is familiar with Dr. van der Kolk, and if you're not, I encourage you to become familiar with Dr. van der Kolk.
So as we move on, as I said, our center and Kim Meyer put together what does that mean? So loss of predictability, what does that mean in terms of how we're going to intervene in the COVID world? So part of it could be, assisting the youth and family in creating schedules and routines. I think one of the things that's helped keep me sane through this is I've got to get up and go to work every day in my office, in my home, but it's a very routine, scheduled thing. And keeping those routine and schedules is so critical. And that can fall away. So we can help families with that. In terms of immobility, maybe this is about, can we have the youth and the family do co-regulation activities together? If in fact you're quarantining together, well, take a walk together, do some outside activities together. You're laughing, Mike.
I was laughing at the way what you were talking about was fitting in what Angie was typing in, where they do a session where the therapist and the client do a similar activity at the same time, even during telehealth. And so it just fits.
Yeah, and you get so creative, right? There's so much wonderful creativity happening through this whole crisis. Loss of connection. Well, you could have scheduled interactions with others. You could think about trying to find a virtual 12-step group. You could link to a mentor via, telehealth as well. In terms of numbing out and spacing out, maybe coaching the youth to create and hone their mindful awareness practice. So each of these points that van der Kolk talks about have inherent, treatment ideas linked to them, and I'll just finish them and then I'll open it up for discussion on it. Loss of sense of time and sequences. One intervention was to mark this time as a historical generational event to remember. So create a COVID COVID-19 time capsule. I thought that was a great idea, right? And you put, what your experiences are in that time capsule. Loss of safety. It's really important, as we talked about earlier with the family violence having an uptick, to talk about creating safe spaces, places of sanctuary in the home, because you lose some of that ability to go to your safe place when you live in a crowded house. All right. So then not only where do you go, but you have permission to go there, and people understand when you're there, don't bother me. I need time to regroup. I need time to, do my coping stuff, and you'll see me when I'm ready to come back out of it. Loss of sense of purpose. Important to develop a sense of meaning for each of our roles in the COVID pandemic. And, I think it's important to keep in mind that maybe the worst, this won't last forever. But I think, creating your own individual but family sense of purpose during this is a great opportunity for families to revisit their family values and things like that. And I think that was it for this set of slides. It was. Okay, Mike, I'm going to let you jump in or people in the chat.
I do want to pull from that. So, and Cynthia brought up that idea. I mentioned it, of doing a similar activity with the client while you're on the phone or in a video conference, as long as you both have the ability to do that. It is nice to have that where you're both doing something very similar. There's a commonality and a connection there. She also mentions using the House Party app, which lets you play games, and that's a nice way to engage, because that's stuff you do one-on-one with youth to allow them to process information in a way that's a little bit safer while they're doing activities like that. So that's great. And Diana mentions coaching families through and cooking together, following the recipe, cooperating that way. Yes, I almost went the cynical direction of what they could be cooking, and I'm not going to do that because this is a positive Thursday, and we're not going to go that direction. So, but those are great ideas, and helping families come up with, because that mixes so many different things that that Vanderkolk talked about, that Rick reviewed, in terms of it's a placeholder, and we can talk about how we came together as a family, and that's when we learned to make Uncle Joe's super hot chili or something and follow the recipe. And really, for me, it comes back to centering on number 6 there on the screen, which is loss of safety. That is the single most important piece to address this, is helping people feel safe. Whether they're coming from a background of complex trauma, it's individual experiences of trauma, or just the anxiety associated with our situation right now is having a safe space. So, and that's in a lot of different ways. So, thank you very much for those of you who are having some really good ideas that are helpful to the whole community.
Yeah, those are really wonderful. We had one therapist that their agency bought like craft activity kinds of things, and they would drop it off on the porch. And then they would call back in later, and so for families of poverty, it's really important that we figure out ways to help them participate in these kinds of unique techniques or interventions that we're doing. So these are really, this is a moment in time. This is a moment in time for every family, and it's really, you can capture that. And it's a memory for each to pass on. And so there's a richness to it that helps families come together in a very different way. The outside, they're coming together against an outside threat rather than an internal threat, right? And that can help families really get closer. And so you want to emphasize that and create activities that emphasize that closeness and uniqueness, really, of what's going on.
Yes.
All right. Opportunity to build family resilience. So identify new youth and family strengths that are uncovered at the time of an external crisis. How has the national crisis brought your family together? What's the silver lining for your family in all of this? How has your family shown creativity or adaptability during COVID? And again, remember that you're in it together with them because we're all going through this together. And we're all learning from each other. And it elevates, it can serve the purpose of amplifying voice and choice, and elevating and leveling the playing field. We're all in this together. We're all learning from each other. I'm really glad you shared that idea with me. I might have to try that one out tomorrow, right? It's an opportunity to begin new routines, minimally around, okay, now you're the teacher. Now what's the routine in our house around when we do schoolwork? What's the routine in our house about daddy having to work? All those kinds of things. It's an opportunity to establish improved relationships. It could be an opportunity for sobriety, depending on what's going on for that family. So think of it also as a time, it's an opportunity to build resilience.
Hey, Rick, I will add,
Okay.
coming from the chat here. I love this one. Some of our parents have put up small tents for their kids to have safe places. As the father of a teen, I can see putting a tent in the backyard as a safe place. But more realistically, in a safe way, if that could be created and coached as a safe place, I can't think of a better idea than that. That is fantastic.
Yeah, that's nice. I like that.
So, and that would be an opportunity then for us, for some of our families, if maybe we could find an avenue to find some funds for some small, little pop-up tents that people can put up in their apartment or their house or something where a kid can have a safe place. And teenagers could be drawn into that too. I know, everything's stupid for a teenager with ideas like that, but I think that they could be usefully drawn into that too, especially if they've got younger siblings.
I like that.
Vision boards. I love this one. In my job, we used a local business owner to prepare cookie kits and did a decorating class over Zoom with our single moms. And don't disclude single dads because we love cookies as well. So, and coaching and how to do it. So, those kinds of engaging activities and what you guys are talking about are ways to really keep people engaged, which is the single most important thing that we can do. I think I've said most important a couple of times today, but from the clinical side, from the helping side, if we don't keep our youth and our families engaged, then we don't have any clinical influence at all. So that engagement is the most important thing you're going to do. All right, I'm done here.
So I'm going to go talk about the tents just for another second. So I love this whole idea of tent for safety, but this whole issue around the dynamics of a small house, okay, and just needing some emotional and physical space. It's a great intervention. So, all right, enough about that for Cynthia because she's probably just feeling really good about herself now. That's it for you, Cynthia. All right. So ASAM guidance on drug testing. So everybody's coming up with new stuff.
He was joking.
This was interesting.
The idea's coming.
What's that?
You shut Cynthia down. She said, "Okay, I'm done." So I just wanted to tell her that she's not done.
Oh, okay. Sorry. So, ASAM came up with some guidance. Mike, I'd love your feedback on this, but, they talked about consider pausing drug testing. Drug testing for routine purposes is not recommended at this point. They made an actual recommendation. Does the benefit of testing outweigh the risk? Are there alternative methods to obtain the information that's needed to manage, the substance use disorder and provide treatment, such as providing screeners to the parents and coach them on how to use them, utilizing oral fluid testing, And I think there might be one more. Hold on. These are all go together, so I'm going to finish this slide, then we'll have a discussion, right? Address the testing expectations with juvenile justice and other partners. Each agency juvenile justice partnership will need to discuss the feasibility, risks, and expectations around drug testing during COVID. So you want to explore the role in the juvenile justice programming, like the diversion program might require it. And you want to have them take a look at their court orders, rules of probation, because it just might not be very possible to do this. So can the court obtain the information that they need in a different way? And maybe you're looking at reduction in criminal behaviors. Maybe you're looking at regular participation in counseling. Now I'll stop a minute, but let's talk about drug testing with our kids during COVID.
Yeah, ASAM came out with that recommendation in March. It was really early on, and as we were starting to shut things down, and I think that it was very much from a public health perspective. My gut reaction was not in strong agreement when it comes to youth in a lot of situations. For probation, if they're the ones doing the drug testing, then keeping them out of the homes. For public safety, I totally get that. But where appropriate, and now here's where the measurement comes. If a family has the capability, the skill level, the non-reactivity level, the parenting skill level, whether it's parent, caregiver, whoever, to implement drug screens meaningfully so that there are privileges and or consequences associated with this. So it has to be parents that have the skill level to do this. Then supporting them in doing the drug test themselves is something that we should be doing anyway, regardless of pandemic. Parents, caregivers, families really should be coached, trained, and empowered to do that on their own, because we want them to take care of that on their own when they can. So in situations like that, I don't see any reason why the drug testing should be halted when a situation like that happens. And I see a comment where, Cynthia, you said that you dropped off tests and you coached parents on how to do it. And when a family system has that capability, then absolutely we should be doing that. So, and I'd be interested in other people with your experiences in that.
So these are the recommendations. Here's some extra thoughts around it. Again, we have to stay adaptable to change our practice, but still have some level of accountability built in for our kids who are using substances. And then how do we coach parents on that as well? Okay. I'm
going to interrupt and add here from Kristen. Any suggestions on how to keep youth or young parent drug-free during COVID to pass a drug test? Kristen, I love that you didn't say clean. Really trying to move away from that language. Very good, drug-free. To pass a drug test to gain employment, to provide for their families. That's the struggle that anybody who is working with youth, young adults, transition age, that you're struggling with anyway, because drugs and alcohol are so often in that mix. But it's complicated now because marijuana and alcohol use are increasing with all of the shutdowns and the decreases anyway, and then our ability to have the clinical impact is reduced. So Cynthia says we increase contact, and as you can do that, certainly that's something that we promote at CIP, where Rick and I are, that really increasing the family involved intensity is a good way to do that when you can get into that degree, and again that comes back then to engagement. So.
Okay, thank you, everyone. These next couple of slides are old now. I mean, it's so funny how quickly. I often say this is a real-time, crisis, you just got to stay on top of things because things are changing so, day to day. But, there was special HIPAA guidance so that we can do telehealth given by the Office of Civil Rights at Health and Human Services, and that still is, there's no DC state on that, so that keeps going. And this is just a slide on all of the HIPAA compliant options and the ones that are not HIPAA compliant, but you can still use them during the COVID crisis. And basically what they're saying is that they are using, they're using discretion in implementing the law, and that's their way of saying, go ahead and do it. Just be careful. Many agencies are just choosing to continue to use HIPAA compliant options because whenever we switch back, it's probably better just to be ready to do it. But the flexibility is important, and I think the flexibility is particularly important around situations where families don't have the technology. So it might not be uncommon for us to use Apple FaceTime because we have to. It's the only one that the family has availability to on their phone or something like that.
Right.
And again, these are things that you've probably already dealt with because, again, we're already months into the crisis. But you want to explain which video conferencing service you're using. You want to be, you want to enable all the available encryption and privacy modes, regardless of the relaxing of the HIPAA standards. You want to explain the privacy risk of using video conferencing technology, and you need to try to obtain minimally, verbal consent to that. And verbal consent during the COVID crisis should be sufficient in most of our states anyway. So it's about just, talking through what are the limits of confidentiality utilizing telehealth. And if you've ever been in a phone call in your home and people can overhear what's going on, the parent, the child, whoever you're doing the counseling with needs to understand there could be some limits on that, especially if it's teleconferencing. They could see and hear. So, yeah, confidentiality, who can overhear your session in the family's home. You need to pay attention to what the family's technology is. What are we doing to help that family obtain technology? Certain foundations, certain agencies are attending to that, where iPads are made available to families. Is there a private space in the house for individuals or a private tent for the individuals to do their session? And as I said earlier, the biggest challenge, I think, is doing family sessions. So these are some of the challenges with telehealth. These are the different resources we use. I do want to make a few comments about sessions in the home and transitioning. And then, Mike, if you have any follow-up comments, that'd be great. And then we'll open it up for any kind of discussion. I think one of the challenges that we're facing now is this whole idea of when do we transition back to seeing our youth and families in person? And so many of us are home and community based because, most of us are system of care grants and agencies trying to implement those grants. So, Mike and I, we do a lot of intensive home-based treatment work. And so all of our services are delivered in the home and community. So we're having a lot of discussions. What would a transition plan look like? What kind of protocols would you have to have in place for that? What is the role of the family voice and choice in that? So, they certainly have full say in whether somebody else comes out to their home. Are you doing them in the home? Are you doing them on the porch? Are you doing them outside? As soon as you do something outside, it brings in a whole another level of confidentiality concerns. So, and then what level of protocol are you using around masks? If families don't have masks, are you bringing extra masks? Are you supplying PPE to all of your staff? Because it's sometimes really hard to find the protective equipment, whether it's a mask or it's Purell or it's wipes. Mike and I joke, I mean, we're both kind of, well, I am, a germaphobe, but, we start every conversation with, hey, what'd you find at the grocery store this week? Hey, I found this, hey, you know what Sam's Club has this week? So, it's hard to find this stuff. So do agencies provide it? And are you using your health departments, either at the state level or at the local level, to help you as an agency? And to get those things, keeping in mind, advocacy is so important for each of us that we need to advocate for ourselves that indeed we are first responders to many families. Think about crisis response. Think about stabilization, behavioral health stabilization. We don't want our families going to the hospital for a behavioral issue unless it's absolutely emergent. So if, in fact, we're first responders, we need to have the same level of protections. So what kind of advocacy are we doing for ourselves related to that? Okay, I'm done talking. Mike, I'll let you add, and then we'll let everybody kind of chime in about anything else.
The only thing I had to add, and I don't think it does not make a practical difference from what you have talked about. But in addition to HIPAA being relaxed, 42 CFR was also relaxed and also has no expiration date with its relaxation. So I don't think that it really makes a difference in terms of what we just talked about with HIPAA. But so both sides have been relaxed. The goal being make sure the services stay available to your youth and your family. Well, to clients. It's not just about you. Just make sure that services stay available and people stay connected as best as possible. So.
Mike, I'm glad you brought it up. So you and I are going to talk in front of everyone. And then anybody on the line right now, please let us know your opinion. So I read the 42 CFR, relaxed language, and I had really a difficult time finding out where they relaxed the law. I know it's something around reporting health issues, but it just felt like it. They said they relaxed it, but I couldn't find out all the areas where they relaxed it. So I don't know if you have any insight on that.
I do not. The only thing that I saw about it at all was a press release from SAMHSA saying it has been relaxed with no expiration date for the duration of the pandemic. That's all I saw, and I didn't see anything specific either.
Yeah, I read through the language, and I go, well, this is kind of, I don't know, the same.
Right.
So
no, I think the meaty part for us is the HIPAA relaxation, allowing for the different deliveries.
So we'll put this out to the chat function, and have any of you seen the new 42 CFR language, and are you aware of any particular areas in it that have been relaxed? I see you getting online right now and trying to find out where that language is. So we'll also open it up to, I'd love to hear from you guys around transition plans. Are you guys looking at, are your agencies basically saying, yes, we're going back out? And under these circumstances, what are those circumstances and things like that?
So looking at the chat box, a couple of comments about school-based counselors and thinking about how many have lost contact over the summer. They probably lost contact before that, in a lot of ways, with all of the changes, and making plans for coming back and whatever coming back is going to look like. And at this point, I think most school districts, at least that I'm working with, I'm sure that it's state by state, but most haven't really committed to a plan just yet. They're still in wait and see mode. And there's not a whole lot of time left, really. I mean, for that kind of planning. Is it going to be a blend of virtual and face-to-face? Is it going to be all face-to-face? You know, and there's pros and cons for both. But for school-based resources, clinicians, counselors, therapists, social workers, case managers, is anybody aware of resources that are going to be out there to help guide students in discussing, you know, as Rick talked about earlier on in the slides, about all the loss that has been associated with this, about the stressors associated with this, the anxieties about coming back. You know, a lot of teenagers think that they're invulnerable, and they're supposed to because that's part of the developmental period. But there's still probably a lot of underlying anxiety about coming back in those big social situations that haven't been allowed up to this point. So planning for guiding some discussions with students about that. So.
And I'll do the next one. We'll go back and forth. So Crystal is basically saying we're doing telehealth as much as possible as long as our state continues to allow it. Yes, we're absolutely seeing that in our state as well. And Kristen, you were mentioning that most areas are giving two learning options, virtual learning and blended learning. That's what we're also seeing in our county. I agree this year is going to look different. We have a small computer lab that we're setting up a schedule for class learning, and we have partnership with the bus system for youth to get free monthly bus passes to get to and from school. And then another one is we provide medication appointments via telehealth if families request it. I'm a case manager, therapeutic mentor, and continue to see clients out in the field, as well as the therapists that I work alongside with. And so there's all kinds of variations on the theme out there, and we're seeing some of the agencies that we work with going back out into the field, and they've been doing that now for a couple of weeks. But now that we've seen an uptick, we're also seeing a retreat a little bit as well. So
kind of back and forth, and you know, with the medication management, the telehealth, but it is still then it's kind of on the backs of case managers, isn't it? I mean, they are the point person so often, and they are the ones that are probably more than anybody putting themselves out there in terms of that very practical help that is necessary to keep these things coordinated. So, you know, as Rick was mentioned, being in some cases like first responders, or I think of it as 1.5 responders. You know, I think that our case managers and our direct contact staff like that should get the preference for the PPE and probably for some sort of Lysol car bomb afterward that you can put in your car.
Wow, what an idea. That's like a business idea.
It is, yeah. If anybody picks up on that, just include me a little bit.
Yeah, this is a Shark Tank idea.
But yeah, for those that are doing the hands-on work, I think that there is, in thinking about us on the clinical side, not you know, in terms of the families that we're serving, but us, there's a lot of processing, and so from supervisory point of view, all the things that we're talking about in helping and supporting the clients through, I think all of us need that same kind of support as well. So,
thank you, Mike. And we're going to keep this open just for another couple of minutes to see if you guys have some other. When I started back in the field a couple of months ago, it was Lysol your body and car and anything that was with you down before coming home. Very stressful and no time to decompress.
Absolutely. It was just it wasn't decompressing, it was Lysoling. Rick and I had a conversation before everybody joined in terms of, are you still Lysoling all of your groceries when you bring them in? it is so anxiety provoking, isn't it? And Rick and I are neurotic, so we might be above where most people are in terms of that anxiety level. But if you're out there in the field and, you know, the news every day is, oh, it's getting worse, it's coming back. Other countries won't even let us in because it's so bad here. It is very stressful, and we do need that time to compress. And if you can have Zoom meetings with your staff and have some of that decompression time, how important is that so that we can continue to deliver the services for the folks that we're talking about delivering them to? So I really appreciate those comments.
Yeah, I think of, you know, something that I am now saying fairly frequently in my trainings, and I'm reminded that when I used to go through airports and we travel a lot, you know, there was always that sign, you know, thanking the military for their service, which is a wonderful thing. And I immediately had this gut reaction, what about us, right? So as we think about, you know, going out into the community now and doing this work with, you know, youth and families who have challenging needs that others have referred to us because there's high risk or high safety issues, compounded now by COVID, we have to thank each and every one of you for all the work that you do. And thank you for your service in helping. What you do is essential. And when I think about the stress that goes along and the added stress now, it just makes me want to do that more. So thanks to everybody for hanging in there and still providing services for the youth and families that are so in need at this time. And that was such a damn good ending point that I don't think I'm going to let anybody else talk now.
That is a very nice supportive wrap-up in terms of thanking everybody for what they do, because they really are putting themselves out there in ways that we just never anticipated. Things were stressful enough in our field as it was already. Finding people to do the work, number one, and doing it for lower pay than we are worth, and just being underappreciated for the contributions that are just kind of subtle and underneath. But now on top of all of that, and billing requirements and getting your paperwork turned in and worried about confidentiality, now there's this. So it is one more thing that we do need time to compress and really thank everybody who does that kind of work.
Yeah, I mean, in the context, Mike, though, that remembering that everyone does get paid quite well.
In that context, yes, everybody on this call today, of course, they're all working from home with Mercedes and Bentleys in their garages in their fabulous homes. With in-ground.
So we're going to end today on a sarcasm note. Sorry for that.
That wasn't intentional at all.
No, but thank you again for everything. And if you have questions, feel free to follow up with either one of us. And I believe, I should have mentioned this right up front. We have a website for our intensive home-based work, IHBT Ohio, IHBTOhio.org. And on that site is the full reference to the Vander Kolk telehealth intervention thing that we developed more fully around telehealth interventions related to his ideas around that. So you should be able to get access to that. All righty.
Well, and before we wrap up officially, Sarah reminds us, please share your feedback on today's webinar using the link that she posted there. That is very important. It really is important. It can be very, very helpful. We have a wrap-up session for our series of talks coming up on July 24th at the same time. And we hope that you can all join us for that. And again, as pointed out, the work you're doing is essential. So keep up the good work, stay healthy and stay safe and stay relatively sane.
Thanks, everybody.
Bye, everybody. Thank you.